Hi, hello? We're Drogheda, we can't hear anything, so I'm not sure what's happening there.
Hello.
We just said that we can't hear anything from Beaumont.
You can hear us now.
Yeah, like that's what we always have done in the past, so I don't think we'll change that this year. I'll clarify anyway, so you know, but usually it's, yeah, this is a medical station or this is a surgical station. Now, the difference with this exam is that some of the skills will be very generic. For example, this is a medical station, please put in an NG tube on this mannequin. Like, it's not like there's going to be a medical mannequin and a surgical mannequin. It might just be that we have a medical examiner at that particular station on that day, do you know what I mean? But for the stations where it matters to you, yeah, like that's what we always have done in the past, so I don't think we'll change that this year. I'll clarify anyway, so you know, but usually it's, yeah, this is a medical station or this is a surgical station. Now, the difference with this exam is that some of the skills will be very generic. For example, this is a medical station, please put in an NG tube on this mannequin. Like, it's not like there's going to be a medical mannequin and a surgical mannequin. It might just be that we have a medical examiner at that particular station on that day, do you know what I mean? But for the stations where it matters to you, yeah, like that's what we... Will I keep going? Yeah. No worries. But there will be certain stations where it will matter. So like if we have someone in front of you and they have what looks like a Charcot joint and they've got loads of venous eczema and they've got champagne type legs and stuff, you're going to want to know, am I to focus on the vascular element of this exam or the diabetic element of this exam? So in that case, we're not going to make you guess. You know, we'll be saying, you know, this is a surgical station, please examine this person's legs from a vascular perspective, or this is a medical station, please examine this patient's legs who has diabetes. Yeah, does that answer your question? Okay. So let me just try the roving mic again. Hello? Okay. Will I just go ahead then? We're not sure if they can access or not. Oh, they can. Good. Okay. So Catherine is going to give me an instruction in 5 minutes to examine, and the first time we do it, it's just going to be an abdominal exam, and I don't know what I'm getting. Okay? Spoiler though, it's renal.
This is a medical station. Please examine this patient's abdomen.
Okay, so hello Sultan, my name's Muirne, I'm one of the doctors, nice to meet you. I'm going to examine you now, is that okay? You in any pain at all? I might be talking to the examiner while I do it, is that all right? Okay, so from the end of the bed I can see that Sultan is lying at rest at 180 degrees, lying down. He is of normal BMI, he has no evidence of any abnormalities in his hands, and I'd like to look closely at his arms for evidence. Oh, and look, there's a mass there on the left arm, and it's compressible, and it's most likely related to being a fistula. So I'm just going to look at your abdomen now, is that okay? So, any pain there at all? Pain up here, okay. No pain while I'm examining there. And this is where the pain is. Oh, I'm sorry. Is that okay? Okay, so I'm going to have to just press a little harder this time. Is that all right? Okay, so there's some tenderness in the epigastric region, but there's no masses or any calor felt, or there was no erythema. I noticed that there is a small scar in the left upper quadrant, and this could be, because it looks open and it looks like a lumen might insert into it, it's possibly for peritoneal dialysis. Okay, I'm just going to examine your liver now. Is that all right? Okay, so I'm going to get you to take a deep breath in and out. So there's no liver edge palpable, so I'm not going to go on to examine for a liver span. And there's no evidence of fluid, so I'm not going to examine for fluids, trail, or a shifting dullness. Okay, I'm going to examine your spleen now. Is that okay? Can you take a deep breath in again for me? And can you just turn slightly towards me? Keep taking deep breaths in and out. So no splenic edge is palpable there. The spleen would need to be about 1.5 times normal size for me to be able to palpate it. I'm just going to put my hand in underneath your back now. Is that okay? On examination of Sultan's abdomen, there was normal superficial palpation, and on deep palpation there was some tenderness, particularly in the epigastric area. The liver and spleen were non-palpable. There were no masses present, nor was there any fluid, thrill or shifting dullness assessed for, because there was no evidence of any fluid. On examination of the kidneys, they were bilateral bilaterally. There was also evidence in the left arm of a fistula. I would like to assess that further to see if it's functioning, and there was evidence of a scar in the left upper quadrant indicating that there has been peritoneal dialysis at some stage. So in summary, the most likely abnormality in Sultan today is that he has bilateral polycystic kidney disease, and he has evidence of previous dialysis. In order to assess if he's getting dialysis ongoing, I would like to look at the fistula for needling. And I would also like to assess his fluid status.
Perfect. 8 seconds remaining.
8 seconds left. Okay. All right. So, any questions on that? Yeah. What's your name? Fiona. Percuss for the no. So if you feel them, so if you felt a liver edge there now, you would. So I'll go back and do the exact same thing again now, but with a liver abnormality, okay? But if you haven't felt a liver edge, looking for a liver span is usually not expected of you, okay? Because that's why you're doing it, right? Okay. Percussion of the spleen, not usually done. If you wanted to percuss for the bladder here, that would be a reasonable thing to add in, but I didn't think I was going to have time, so I left it out, because in this exam, what was it going to add? You know, if this was doing a renal exam from a urological point of view, they probably would want you to percuss for the bladder, but you see, mainly what you're looking for is bladder distension. So that's kind of more a long case situation where someone has been, they're either post-operative or for some reason they've got an indwelling catheter, besides being post-operative. Any other questions on that one? Okay. So I'm going to go through the exact same thing again now, but I will show you what I would do if I had come across a liver edge instead. Is that okay? In terms of a spleen exam, there's not an awful lot more that you can do besides what I just did. Okay. So how many people here have felt a large spleen? So about, I would say 20 of you, so not the full group. What you will notice with someone who has a large spleen is from general inspection, they will absolutely have a distended abdomen. It's pretty hard to miss. It won't usually be distended on one side, but it will look asymmetrical. Okay, so they'll have distension throughout, but it will look slightly more so on this side. And then when you go to feel for it, it's kind of hard to miss when there is a big spleen there. Anyone here who has missed a spleen when they went to go examine it and they were told it was big afterwards? No one wants to admit that anyway. Okay. No, it's not a subtle finding is what I'm saying. The other thing I would say is that splenomegaly is very difficult to find these days in terms of patients who have it who are willing to do an OSCE. Think about what causes splenomegaly. Give me some causes. So liver failure with portal hypertension, yeah, sickle cell disease, several other hematological diseases like, sorry, I just can't hear you. Leukemia, yeah, absolutely. So any hematological malignancy can do it. So leukemia, lymphoma, then the myeloproliferative disorders as well, so things like MDS and CLL. So if you think about it as liver disease related, hematology related, and infection related, that's probably going to cover most causes, okay? So with liver disease, it's portal hypertension that causes it. With hematological disease, it could be a malignancy, it could be a myeloproliferative disorder, or it could be one of the inherited hemoglobinopathies, so sickle cell disease, thalassemia, hereditary spherocytosis. And then infections. What infections do you know cause it? Malaria is the commonest one known, but in other parts of the world, Kala-Azar as well. Ask me absolutely zero follow-up questions about that, because I have never seen it, nor will I ever, probably. So your colleagues who are watching this video in Malaysia and Bahrain, firstly, hello, but secondly, they're much more likely to see big spleens on a regular basis than you are. Why? Because some of those things we talked about are much more common in those countries, such as sickle cell disease, very common, and malaria would be slightly more common, and thalassemia, yeah. Okay? So don't get, I'm not saying spleens aren't going to come up. What I'm saying is, if you haven't seen a spleen yet, don't get overly worried. My point is that when they are there, they're very blatantly obvious. Okay, so I'm going to go through the exact same thing, but from more of a liver angle, all right? So
this is a medical station. You have 5 minutes to please examine this patient's abdomen.
Okay, so Sultan, you look familiar to me, but nice to meet you. I'm going to just examine your abdomen now. Is that okay? I'll be talking to the examiner while I do it, all right? Do you have any pain anywhere? No, okay. So on examination of Sultan, he is lying flat on the bed and appears comfortable. He has no indwelling lines or catheters. There seems to be a scar on his left arm. Oh no, actually it's a tattoo. And there's nothing else visible on general inspection. So then on examination of the abdomen, I note that there are no scars present, but there does seem to be a small amount of fluid, which I'll assess in more detail in a while. Any pain in the abdomen at the moment, Sultan? Okay. So let me know if I'm hurting you at any point. Okay. It's a little bit sore in the right upper quadrant. Okay. So a little bit harder this time. Apologies. Okay, so also sore there. Okay, so can you take a deep breath in and out for me, please? Okay, can I get you to put up your finger just there for me? Thank you very much. So the liver span there looks like about 7 to 8 centimetres, which is normal. I'm just going to put my hand here for a second, Sultan. Is that okay? Sorry, can I get you to put your hand there for a second? I notice there's a very mild fluid thrill there, so that's fine. So I'm just going to feel your abdomen here again. So I'm after going from resonant to dull there. Can you turn towards me? Okay, good. I'm just going to wait here for about 15 seconds. Now the dullness is gone from there, and now it feels resonant, which would indicate that there is shifting dullness. Okay, thank you very much. I'm just going to feel your spleen now, okay? So take deep breaths in and out again. That's fine. I'll get you to move slightly towards me. Okay, and so no palpable splenic edges felt there. Now I'm just going to put my hand in underneath there. Okay, and the kidneys weren't palatable. How much time?
1 minute remaining.
Okay, so on examination of Sultan, he had a normal superficial palpation other than the evidence of some fluid present. Deep palpation was normal other than some tenderness in the right upper quadrant. There were no palpable masses, nor was there organomegaly. On further examination, a liver edge was palpable, and this was non-tender. However, the liver was about 7 to 8 centimetres in span, which is normal. There was fluid thrill and shifting dullness present, indicating that there was some ascites there. I was unable to palpate a splenic edge, so it would indicate that he possibly does not have portal hypertension. However, I'd like to assess further by looking for evidence of varices and caput medusae and spider nevi. On further examination, the kidneys were not palatable. In summary, Sultan has a palpable liver edge, which is probably related to chronic liver disease, which is more likely to be C2H5OH or viral due to the fact that the liver is enlarged, and there is a tattoo present as well, therefore evidence that there might be a risk for hepatitis. Okay, any comments on that? Yes, what's your name? Kat? Cass. I would say that if it's a physical examination station and they haven't asked you to do a specific functionality thing. So for example, do you remember before we did ones where it was like, look for complications of transplantation, or I might ask you to demonstrate the findings of Parkinson's. In those ones, I'm not looking for a diagnosis, right? But if they've just given you an examination and they've asked you to present your findings, I would say try to give a diagnosis. You're not going to pass or fail on whether you give a diagnosis, and you certainly aren't going to pass and fail on whether it's right or wrong. But it's a good idea to make an attempt to show that you are trying to analyse the information that you've picked up and put it together. Okay? So, for example, I've had many students come in and they've done a very good cardiac exam. Technique was very good, but at the end they've said there's a murmur present, I think it's mitral regurgitation, and it was actually aortic stenosis. They can easily still get 75% on that because they've done the stuff correctly in the way that would be safe to do it as a working doctor. They've picked up the abnormality, i.e. a systolic murmur. They didn't get exactly where it was, but they've got very far there. If they had just presented their findings and hadn't made an attempt to give a diagnosis, you'd probably be thinking more about 60, 65, because they haven't tried that extra step of putting it together. Does that answer your question? What's your name? Drew. When you're doing fluid thrill, you don't have to do it, but what often happens with fluid thrill is that people look for a flick rather than they actually feel for the flick. Okay? And so when you do that, they're less likely to see just this transmitted flicker. So like, if you have no fluid at the moment, I have no fluid, but I do have fat, my fat will flicker quite nicely, right? And you could theoretically say that I have ascites when I really just ate a scone for breakfast. So that's why we do that, the idea that it's more likely to transmit as a fluid if you put your hand there first. I think it's a fairly soft thing. If you didn't do that and you just did that, would I mark you down? Absolutely not. But it's what I'm used to doing. Now, what's your name? Bardi. You've sent me an email. I haven't answered it yet, have I? I'm sorry. But I was coming to it. And what I might do is answer it in front of everyone at the end today, because a lot of the questions you asked are questions other people have asked. Oh, the surgeons love if you name the 9 areas they have done. The medics don't really care. They think that if you're able to count to 9, you probably know what you're doing, okay? So don't listen to me in terms of what to do here if you are in a surgical exam, because they have some very specific things that they want from you. We are a bit more flexible around that, okay? What you will notice is that I did go down on my knee for the general inspection of the abdomen and the superficial and deep palpation, okay? So you should absolutely do that if the height is a correct height, but you know, sometimes the beds are up this high and you might be a smaller person and therefore that's not going to work, but you should attempt to do it. The important part isn't really being on your knee. The important part is that the abdomen is at eye level. That's what they're looking for, okay? And then you saw for the first time, because I had got up, I examined the liver while standing up. I hadn't got up the second time, and I did it while kneeling down. There's no difference in that. It's the superficial and deep palpation that you have to be at eye level for, okay? Any other questions? Yeah, what's your name? Eva. Good question. So other than the abdomen being distended, is there any other signs on inspection that there could be fluid there? So the most common cause of fluid in a medical abdomen is going to be ascites, and therefore the most common cause of ascites in a medical exam is going to be chronic liver disease. So if they have fluid elsewhere, that's certainly going to help you, so like ankle swelling, because that will confirm to you that what you see as distension isn't just fat, it's fluid. But then all the other stigmata of chronic liver disease are what you're looking for, really. Things that will really help you is if they have other features of portal hypertension, which are the caput medusae and the spider nevi. Like, you're not going to be able to see rectal varices or esophageal varices on general inspection, obviously, but those ones you might be able to see. So just think about looking at the person from the point of view of other liver stuff. Like, I could have said at the end here, oh, look, he looks a little bit discoloured, and on the hands there's evidence of wasting of the small muscles of the hands, and there's some pruritic scratch marks, and he also has some bruising, so maybe he has a bit of coagulopathy. You could potentially look at his hands for asterixis, but I don't think you really have time in those 5 minutes. If they have loads of findings on general inspection related to liver disease, but you are asked to do an abdomen exam, if you pick up on 2 or 3 of them, we would be delighted. You know, we understand that you don't have time to look in any more detail, all right? It's just to let us know that you are looking with an educated eye and you're not just thinking, oh, this could be anything. Because that's fine at third med level, but at final med level, if you're asked to examine an abdomen, you should know, well, there's probably only 4 major things that this could be in a medical station, so I'm training my eye to look for things related to that. Does that make sense to you? Okay, so the last one then that we would do is the instruction if we were given we were told already this is a renal station, right? And the question that you're asked is to determine the functionality of this patient's kidneys. And so in that context, it could be, oh, this is someone who has chronic kidney disease and they are receiving dialysis, or this is someone who has chronic kidney disease and they are not yet receiving dialysis, or this is someone who has a transplanted kidney and that's working. Or number 4, this person has a transplanted kidney and it's not working. So let's talk a little bit through those different options firstly. So someone who has chronic kidney disease and they're receiving dialysis. That's the easy one, isn't it? Because they have to have some way of getting dialysis. So on either general inspection or when you get up closer, you're going to see features of that. So when you're doing your general inspection, what's your educated eye looking for? Evidence of fistulas, evidence of anything in the neck, and evidence of peritoneal dialysis. So is this the ideal sitting point position for him, for you to examine for that? Probably not. You probably want him sitting up so you can see his neck too. So is that okay, Sultan? Thank you. All right. right? So that's the first thing you would be thinking about, isn't it? And then if you see a dialysis access point somewhere, that's really helpful. In the case of someone with chronic kidney disease, are we expecting that they will have a tunneled line or a central venous line up here? No. But is it possible that they could have scars from having one of those previously while they were awaiting a longer term option? Yeah. Let's say you've got your patient who comes in with a profound nephritic syndrome, okay? A young woman, and she has an autoimmune disease. It could be lupus. It could be that she has a pulmonary renal syndrome, Sherk-Strauss or good pastures or something like that. She comes in profoundly unwell, needs to start dialysis immediately, and then needs to be on dialysis long-term thereafter as well. So initially she got her dialysis through a central line up here, or they tunnelled in a catheter into a PICC line or something like that, while they waited to get her well enough till they could come back and then put in different access, which could be a fistula or peritoneal dialysis. Yeah? Everyone still with me? Yeah, okay. So you would look for the scars there, and then obviously you're going to, as soon as you've done a general inspection there, get on to looking at the arms. And you're going to feel the arms too, aren't you? Because sometimes, as we said, sometimes these fistulae might not be as obviously distended as you expect them to be. I've seen people with fistulas and their arms don't look much different to my own. But then when you feel them, you can feel, how will you describe it? Soft and compressible swelling, isn't that right? Yeah, great. See, you are listening. And I see you might be a kinetic learner, whereas I'm much more of a visual learner, so you're able to learn just by doing it afterwards rather than writing it down. So I shouldn't have been commenting on that. You can give me bad feedback at the end of the year, okay? So you're going to be doing that. And are you going to start doing like augmentation tests and obstruction of that? You don't have time to do any of that. So all you were doing there was determining, is there a fistula there or not? So that's enough, right? Looking at it, finding it, saying it's soft and compressible. And if you want, you can ask the patient, Sultan, are you right or left-handed? Right-handed, so therefore you're going to look at his left arm first, because we try to do it in the non-dominant arm, okay? But you don't have to do that, it's just to save you a bit of time. If you didn't see anything in the arms, then you might look at the abdomen in particular. This is the area where we're going to be looking. The left upper quadrant is the most likely place where they're going to have put in a peritoneal dialysis catheter. And probably a 1 to 2 centimetre opening. A lot of them will have nothing in it when they're not on active dialysis. Some people will have one of those like little stopper bungs that they keep in it. But they're quite subtle looking, okay? And then obviously if they were in active dialysis, they might have an actual catheter coming out of it. So that would be in your long case. In your short case, that won't happen, okay? But you still need to look for it there to see if they're potentially getting access there. And other things that you need to think about of peritoneal dialysis is, what if there are other scars there? What are common complications of peritoneal dialysis? So it fails, but they can also get peritonitis and things like that. So is there a possibility that they might have had their abdomen, they might have had surgery done or anything like that? There is, okay? So you need to look for scars from other procedures at that point. Hopefully it would have been caught early and they could have been treated just by removing it and giving them IV antibiotics in the full sepsis protocol. But in some occasions that will not be the case, okay? So then, once you've done that, what do you think would be the next thing that would be appropriate to do in this situation, where the instruction you've been given is renal examination, comment on the functionality of this patient's kidney. So are you fairly happy now that this person is getting active dialysis? Yeah. So they have a fistula there, there's some needling on it, or they've got a clearly open peritoneal dialysis lumen. Okay? So what else would you want to determine then? Just want to rule out that they'd have a transplant, wouldn't you? Okay, because could it be the case that they are now on dialysis after having a transplant that has subsequently failed? Yeah, that was number 4 in my options, wasn't it? So don't you still need to check that if there's a transplant there or not? And then shouldn't you just check for the native kidneys as well? Because if they're ballotable, that might give you an indication of the etiology. What's more likely? In the vast majority of chronic kidney disease, will you have ballotable kidneys? No. So let's think about the common cause of chronic kidney disease again. So diabetes you can get in large kidneys, but it doesn't usually happen. Hypertension, glomerulonephritis. So in most of these conditions, what you're going to get is shrunken atrophic kidneys. Remember learning about that? And there's certain radiological findings you look for. So in the vast majority of causes, you will not expect ballotable kidneys, correct? So if you do find ballotable kidneys, wouldn't you be confident enough to say, okay, this is a patient who is on active dialysis and does not have a transplant present, and their kidneys are ballotable, so I believe that this person has chronic kidney disease as a result of adult polycystic kidney disease. And to examine them further, I would like to take their blood pressure and a history of headaches, collapse, and berry aneurysms. Yeah? Yeah? Wouldn't that sound pretty slick? Sultan gives it approval. Right, so will we go through that quickly, and then we'll talk about the other ones. We don't necessarily need to go through them all one by one. Is that all right? So you're going to give me my instruction and just give me my 1-minute warning.
This is a medical station. Please examine this patient's renal function or renal system, or do a renal exam and comment on the functionality of his kidney or his renal status.
That's fine. Hi, Sultan. My name's Muirne. I'm one of the doctors here today. I'm going to just examine you now. Is that all right? I might have to take a look at your arms and at your tummy. Is that okay? Any pain at the moment? Okay. So on general inspection, Sultan is lying at about a 30-35 degree angle and he looks well. Can you put your hands on your hips there and just take a deep breath in and then push air out? Yeah. Okay. So I don't see any congestion of the veins in the neck or in the arms that indicate he might have a tunneled line there. Okay. I'm just going to look closer there, Charles. Which hand do you write with? Just looking at your arms there. Oh, so I see there's a mass here. Is that sore at all? Okay, I'm just going to, and I see that there's some needle marks in it there, which indicates that it's possibly an active fistula. I'm just going to feel it there quickly. Yeah. And it's soft and it's compressible. And I feel a continuous thrill through it. So I think that's a functioning fistula that's there at the moment. Okay, I'm going to lie you flat now. Is that all right? Still comfortable? Okay. So I don't see any scars on the abdomen currently. Any pain at all in the stomach? Okay. I'm just going to feel it there and you let me know if there's any pain at all. So superficial palpation, no tenderness elicited. I'm going to just do that a little bit harder this time. There's no organomegaly palpation on deep palpation and no masses felt, and specifically no transplant identified at that point. Okay, I'm just going to feel your kidneys now. Is that okay? I'm just going to put my hand in here. Okay, again. Right, so the kidneys are not ballotable there. Can I get you to sit up again for me, please? Stethoscope. Have you noticed any swelling in your ankles at all lately? This week, okay. Okay, so there's a small amount of sacral edema there. Can I get you to sit up fully for me there? Okay. Sorry, I don't need that. Yeah, I'm just going to listen now. Can you take a deep breath in and out? So on examination of Sultan, he was sitting comfortably at rest. There's evidence of a swelling in his left arm, which was soft, compressible, and with continuous thrill. It also had needling on it. So, and I noticed that there was a buttonhole on it too. This indicates that it's a fistula that is being actively cannulated. On On superficial and deep palpation, there was no tenderness present, nor was there any organomegaly or masses detected, specifically no kidney transplant. The kidneys were not ballotable. In terms of his fluid status, he had some bilateral ankle swelling, but there was no evidence of crepitations in the lungs or evidence of pulmonary edema, and nor was there any evidence of renal bruise on auscultation. So in summary, this is Sultan who has evidence of chronic kidney disease for which he is receiving active dialysis. It's probably in between dialysis sessions, as there's evidence of some fluid overload currently, which is mild. I'd like to get his dry weights and his wet weights to determine how much of that. And the etiology of his kidney disease is probably due to either diabetes, hypertension, or glomerulonephritis.
Great.
Okay. Anyone, any questions on that? So that's one possibility, chronic kidney disease, and what you're looking for is evidence of how the kidneys are functioning. Kidneys could be functioning by themselves, completely normally, unlikely to be in an OSCE station. Kidneys could be chronically deteriorating. Main feature that you will find on physical exam then. So remember we talked about it last week, the history of chronic kidney disease. The things that start to go off is that they start to develop fluid overload, their blood pressure starts to go up, their potassium starts to rise, and their urea and creatinine start to rise. Yeah? Which of those can you actually find on physical exam in 5 minutes? Fluid overload and blood pressure, yeah? And is a one-off blood pressure reading, particularly in an exam situation, going to be that helpful? Probably not. So fluid overload is really the only one that would be that useful to you there. So we might have someone who just has evidence of fluid overload and otherwise their renal exam is normal, okay? What's the most likely mistake you are going to make in that situation? Invent signs, okay? So say that you found a kidney transplant because there's an appendicectomy scar there, or you felt ballotable kidneys when they weren't there, okay? It happens all the time though, because people are like, but I was told to do a renal exam and there was no renal findings, okay? But the commonest renal finding that you will see in a chronic kidney disease patient is fluid overload, okay? They may not actually have an awful lot going on up here. That doesn't mean you don't look for it still. Just don't pretend it's there when it's not. Present what you actually found as opposed to what you think you should be finding. We had membership exams a few weeks ago. We had the exam board last week. The most common reason someone fails their memberships is that they cannot identify physical signs, and the most common mistake they make in identifying physical signs is overstating things and saying that there are findings there that are not. Okay? So try to get that under control at Final Med, and then you'll fly through your memberships as well. Then, sorry, Bart T. Yes. So if you see both a transplant and an nephrectomy scar at the same time, the most likely cause then would be polycystic kidney disease, but then they should have bilateral nephrectomies. If they only have one, what's the other thing you should be thinking about? Transplant for? Sorry? Cancer, yeah, renal cancers. Okay, so someone had localized renal cancer disease. That all right? Okay. Yeah, Amina? Yes. Yeah, so it's a fair point to ask about. So when you're looking at the neck, you might see that they have scars there related to parathyroidectomy. If you did see a scar there, you could think, okay, well maybe this person has had a parathyroidectomy, and you wouldn't be wrong to say, I'd like to test Chofstek sign and Trousseau's sign. The reality is that if someone has hypocalcemia, it's probably not acute hypocalcemia, it's probably chronic, and those signs are unlikely to be positive. Secondly, they're a bit awkward to do, you know, putting a tourniquet on for Trousseau's sign and all that. Chofstek sign is easier, but Trousseau's a little bit. So I would just say I would like to test them as opposed to actually going out doing them, because they're most likely to be negative, but it's good for the examiner to know that you know to look for them. Okay? Now, if this was... is everyone happy that we would have the exact same sequence of events, except if he had a transplant as well? When I did my deep palpation, I would then say, oh, I found mass here, and it's about a 6 centimetre by 2 centimetre mass, and it is kidney shaped, and the skin above it seems to be normal, and it is not. It is slightly movable, but non-adherent to below. And if you want to, you can get out your torch and start seeing if it's transilluminable or not. I mean, I'll probably laugh in your face if you do, because it's not a surgical exam, but you wouldn't be wrong to do it. It's just not very high yield. Okay, so, you know, if there is a mass there, you describe what the mass is. But from my point of view, what do I want to know about the mass? I want to know, is it red? Is it tender? Does it look like it's been biopsied? Otherwise, it's just a kidney transplant that's sitting there, happy out, yeah? If it has any of those features, it's probably being rejected. So in this patient who has chronic kidney disease, who has just come in for the OSCE, is it likely they are going to have a red, tender transplant that has biopsies on? No, it's not, is it? Okay, so all you'll be saying is it's this length, it's that wide, it's kidney shaped, the skin above it looks normal, it's consistent with a kidney transplant. Yeah? And how do you know if it's working or not? Are they on dialysis? And are they fluid overloaded? Okay? So if they're on dialysis, it's obviously not working. Yeah? Is everyone happy with that? Okay. So you don't go from having a kidney transplant to it failing to you being fine. You have to go back on to dialysis, yeah. So would you all be happy to try practicing those different scenarios? So one, chronic kidney disease patient whose only finding is fluid overload. Second, chronic kidney disease patient who has fluid overload and also has blottable kidneys. Chronic kidney disease patient who has a transplant and doesn't look like they've any evidence of fluid overload. Chronic kidney disease patient who has a transplant and looks like they're getting active dialysis. Yeah? Okay, so there's a few different permutations. And the main things are, after your general inspection, look for evidence of dialysis going on, which is going to mean mainly the arms, looking for peritoneal dialysis here too. Look to see if it's active. How do you know if it's active? In the fistula, there'll be needling and there'll be buttonholes. The fact that there'll be an open lumen at all on the abdomen means that there's peritoneal dialysis, which is active, because that'll close up quickly when it's not active. Then do your superficial and deep palpation, looking specifically for kidney, then blot your kidneys, and then, if you have time, try to look for evidence of fluid overload, like feeling for sacral edema, feeling for pedal edema. Sorry, I felt for pedal edema and I presented it as sacral edema. That's not what I meant. I meant pedal edema. When you look back at this, you can know that that's what I meant. And then listen in the bases of the lungs for fluid as well. Okay? Everyone happy with that, or as happy as they're going to be for now? Yeah. What time are we at? Okay, so I think it's time you need a little break. Is that right? Yeah, so 11:38, so can we start back at 11:50, please? And thank you very much, Sultan, for your help. Hopefully there's not too much feedback on that. Now, hopefully Dorsey's Wi-Fi will work here. Unless the specific instruction was to do an examination of the JVP. Okay. Start doing all the other stuff. Thanks. Okay. Go. I'm sorry, I'm not looking at you. I'm trying to upload something at the same time as talking to you. Okay.
No problem. Just given up the sort of chronic kidney disease is a relatively new exam that we've not been doing since Fusia. I just find it a bit tough that the different combinations of findings, each one has like a specific I just like kind of want some general advice, to showcase how to go about practicing specifically for this.
Make friends with the nurses in the dialysis unit is what I would say, and go and spend an afternoon there examining the different patients with different abnormalities.
Okay, and
Get comfortable with looking at different fistulas and asking them, can you feel their kidneys and feel their transplants, because some people's transplants feel a bit different to others. We have one patient who has 3 transplants, and people always only find 1 or 2 of them because he's had loads of different abdominal surgeries done. His abdomen looks weird, right? So when you go looking for them, they're not exactly here and here. One is like here and one is up here, kind of, and then one's hidden in here. Okay, so that's what I would suggest doing. Going down there, making friends with the CNM, and tell them, look, I've never been in a renal place before. I know it's really important. I want to be good at this. Like, the nurses there are really helpful, and they say, oh, this patient is useful and is willing to talk. This patient got bad news, doesn't want to talk. And then after you see the patient, there's usually meant to be a reg on dialysis all the time. So go and ask them, did I find the right thing? Or ask one of the nurses, because the nurses down there are so specialised in renal that they'll be really helpful to you. There's also a full renal video online of me going through the renal exam from top to bottom, general inspection, the arms, etc. I would watch that before going as well. Okay?
No problem. Thank you.
There's also often renal patients who have had successful transplants on Mary's ward. So I know they've been strict on T-shares and very strict on babies. But the first kind of couple of days on Mary's ward, there's often patients who are in that have a background of having had a transplant. So if you can't get one elsewhere, ask the nurses, just kind of pop up and say, is there anyone on the board that has a transplant at the moment? And often there is 1 or 2 even there, even if they're in with the flu that they have, or not flu, so it'll be like, but they're in with something else and they have a background of a transplant, they're often brought there.
That's a good tip, I didn't know that.
Yeah, the T-shares is kind of a bit oversubscribed.
Yeah, it makes sense.
I just had a question about the 4 types. You said that there was CKD with fluid overload only, CKD with fluid overload and blockable kidneys, transplant with on dialysis, and then what was the other, the 4th one?
Just a transplant that's working.
Without dialysis.
Yeah, so now they might have evidence of having had a previous fistula, because
Okay,
very
but it
few
would be
people
operated.
just get a transplant, right? But it wouldn't be an
In
active
use.
one.
Okay.
Yeah, exactly.
Alright, no problem.
Is
Thank
that
you.
okay? You're Simran. Shivran. And are you one of the class reps?
No.
There's someone with a similar name then, and maybe is it Simran?
Simran, she's a girl, yeah.
Simran and Shivran. Okay, because I was trying to figure out the faces.
Yeah, no problem.
You're like, no, I don't want that responsibility.
Should I just ask here to change the password? Okay. So just how to change it again now.
I know.
They're all passwords.
Where is this gone?
Is there something you want on the list?
Yeah, I want to, but I haven't put it up here yet because I thought I had, and then I obviously
log in this stuff.
So yeah, if you try now, you should be able to find it there. Yeah, it was there. I just was looking at the wrong place, so it's down at the end because I didn't put it into a specific folder because it's not really real.
Don't tell me they've locked me out again.
No, this kept
Very
happening
upset.
to me, but it kept changing back to
Here's
here's
password. No, it wasn't. Last time I checked. It was done in the junior year.
So this is what Ray said we need to do. It looks like you've already done it. The contents up there.
Yes.
And so then when
Yes, I texted you.
we want to go back to starting here, across the stop and push again
On this, is it?
on the remote. He had a
Ray
remote.
have it. We turned down the volume on it. Here.
Well, look, we may not even get through actually acting it out. We may just get it through the
Yeah,
So it's just this one.
Yeah, I think that can only be done on the.
So I think it's this one.
I mean, we could stop content from the RCSI PC maybe.
We'll see. I might want to get through actually going through
Go
this.
through it. Yeah, perfect. I'm going to pop in the bathroom.
Yeah, that's perfect.
So I started incorporating like more specific things back then. It's on like if it's on your journey. Just like the snapshot of like just looking at conversions, like going up and down arms.
Hello. Okay, guys, we'll get started again. Okay, so we are going to talk now about one of the ComSkill stations, which could be disclosing a medical error to a patient. Okay? And the one we're going to talk about is that a patient was given contrast in a renal radiological exam when actually contrast was not part of the protocol. Okay? Why would that be important in renal disease? Contrast is nephrotoxic, so if they have ongoing chronic kidney disease, you could cause an acute on chronic insult, and that could be quite damaging to their kidney function. Okay? So, but before we talk about that specific situation, we're going to talk about the principles that should apply to any situation in terms of open disclosure. Okay? So the HSE has an open disclosure policy since 2012. A lot of you who have lived and worked in Ireland for a long time might be aware that there has been a lot of media reports about cases in the past in Ireland where there was not open disclosure, particularly around poor neonatal outcomes. And so that was one of the reasons why this came about, because the public didn't feel that they could trust their doctors and healthcare professionals in giving them the correct information in a timely fashion and showing them that they were trying to acknowledge when problems happened, etc. So it's a really important skill for you, and I think as an intern you will very often be the first person who has to talk to a family when something goes wrong. And the vast majority of these things are small things, but from the point of view of someone who is a patient, any error can significantly add to their distress. So it is important that we respect how upset they can get about something that you might think doesn't really matter, like they took bloods from me that I didn't need to get done, for example. You might think, okay, well look, nothing really happened to you, it's only blood, it doesn't really hurt or anything, but what could be going through their head is, but my hemoglobin was already 6. Now it might be lower. What about if I could get an infection? I've heard that people get infections through needles. You know, so they might have a whole lot of other things that they are thinking about that are causing that to be more stressful for them. So this document is up on Moodle if any of you want to download it now. And it's a short open disclosure document. The HSE has a much longer one as well. But there's a few bits I just want to show to you in it. So I think we use the Australian definition of what a medical, what open disclosure is. So an open, consistent approach to communicating with patients when things go wrong in healthcare. That's obviously something we could also ask you in an MCQ. How to define open disclosure. We wouldn't ask you that in an OSCE because an OSCE is meant to test your skills as opposed to be a knowledge test. And then if you scroll down further, please, Catherine. So there's a whole list of different things that you are meant to do during it, and I think all of these will sound quite intuitive to you. So if we just move back to the start, these are the ones that are going to be more important to demonstrate in an OSCE, and I'll explain to you why. But acknowledgement that an error has occurred. So explain to the person that what happened should not have happened is essentially what you need to do, okay? Which sounds very straightforward, but has not been the case in the past. Often people have been told, oh, well, we did this, but we did it because we meant this, and they tried to cover their tracks, as opposed to saying why. And truthfulness, timeliness, and clarity. When do you think someone should be told when an error has occurred? As soon as it's identified. So what about if you were in the OSCE station and they were saying, oh, but this happened 2 weeks ago, why am I only being told now? Okay, so you'd have to manage that situation and say, okay, well, we didn't follow our own policy there, essentially, and that you're sorry about that happening. And we'll talk about in further details what you would go into later. I'm sorry about all the feedback on this. Can you still hear me if I hold it like that? Okay. So then the apology, this was the one that was probably always underrepresented. I think for a long time, doctors and other healthcare professionals were given the advice that if you apologise for something, you were admitting responsibility. Now, firstly, if you did do something wrong, you should admit responsibility. So I have no issue with that. But even if you're in this situation, so we could give you an OSCE situation where it's like, the last intern gave blood to the wrong patient, and that intern has gone home now, so you're the one who has to go and tell the patient, right? So instead of saying to them, well, it wasn't me, I didn't do it, it's not my fault, which is sometimes what has happened in the past, you still should be apologising that this happened to someone, yeah, and because you wouldn't want it to happen to you, you wouldn't want it to happen to anyone in your family, so I'm sure the same applies to any patient. And in a minute, we'll show you some of the language that they suggest is used around these things. So those are the things that if you remember nothing else for an open disclosure station, you should remember. Acknowledging what has happened, being truthful and timely in trying to address it. And if the timeliness has not occurred, apologising for that. And then apologising for why the thing has happened and expressing regret about it. The other parts of it are less easy for you to do. I mean, if you look at recognising the expectation of the service users, do we recommend that you ask them how they feel about this and what they would like done? Absolutely. Is it likely that in 5 minutes you're going to be able to come up with a comprehensive answer to that? Probably not. Okay? So the expectation of you would be that you would certainly try to open that conversation with them about how they feel about this and what should happen next. But we wouldn't expect you to come up with sort of a full answer. I mean, a lot of the problems that occur with relation to medical error are systems errors, like one person wrote a note and the next person couldn't read it fully, so then they transferred that into the prescription and actually they got 2 letters in the drug name wrong, and then the person got Serenase instead of Seroquel, or vice versa, and very different drugs working very different ways. And then the nurse just presumed that it was the correct drug instead of looking in the notes as well as the chart, because that's what they would do, and then it was dispensed, etc. So loads of different places where small errors went wrong, and therefore one big error happened in the end, which was that the patient got the wrong drug. So you'd have to be able to fix all of those things to be able to achieve all of the steps here. Obviously you can't do that, and you particularly can't do it in 5 minutes, so we won't expect that. So numbers 1 to 3 we would absolutely expect of you. Number 4, you should recognise the expectations, but you may not necessarily be able to address them fully. Numbers 5, 6, 7 and 8 are much more difficult for you to demonstrate, particularly in an OSCE station. So you can't identify a full professional support network. What you could do to them is say, do you want to have a follow-up meeting with the social worker or with the psychologist, or do you want me to call your GP to explain to them what's happened? Do you want to have a family meeting where a member of your family is here as well as me and the consultant, etc.? So that's the kind of thing that's appropriate for you to ask as an intern. Okay, so different options of other people within the multidisciplinary team who might be of support to them during this. Risk management and systems improvement, you're not going to be able to achieve. Okay, you by yourself can't do that. But what can you say? That you will record what has happened, you'll communicate it to the consultant, and you'll see what processes are going to be considered, put in place, and maybe you'll get back to them about it, yeah? In the specific example that I'm talking about, where someone got contrast when they shouldn't have got contrast, where are the potential places where the problem could have arisen? So the patient comes into hospital, someone on the team decides that they need a CT scan. Okay, and then the intern usually orders the CT scan, and then when the radiologist approves the CT scan, then the radiographer brings them into the room to get it done, the porter brings them down to get it done, and the radiographer usually gives them the contrast if it's to drink, if it's IV contrast. The radiologist will administer it, so it has to be on a drug chart. Someone's had to prescribe it there. So, is there one place where this could have gone wrong? Are there many? Okay, yeah. So you'd have to have knowledge of that process to be able to come up with some sort of answer to them when they say to you, "Well, what are you going to do about this?" Yes. So, give me some solutions as to things that could happen. Because an awful lot of the medication errors that you're going to deal with are going to be around similar situations where multiple people interact with the patient in order for that thing to be dispensed to them or administered to them. Okay, so there could be a checklist in terms of the history to identify if there is any contraindications. Okay, the issue here was that the patient was never meant to get the contrast, so it wasn't a plan in the first place. So that wouldn't help in this case, but it would in other ones. What else? Yeah, so maybe when you're ordering the test, could a note be put onto the test that that contrast is a contraindication, just in case? Yeah. Maybe the intern needs to phone the radiologist and speak to them directly to say it. Maybe on their prescription, on the front where it says NKDA, you might also have a sticker that says, do not administer contrast. So there's lots of potential solutions is what my point is. When you're in this situation, you're meant to think on your feet and think of what might be one practical solution. Like any of those, if you came up with any of that kind of stuff, we would be delighted with you. And if you said, I don't know what the particular answer is here, these are some of the places where I'd imagine that this could have been a problem, and then I'll bring it to the attention of my consultant and we'll try to come up with some strategy to avoid it. That would also be fine. Because we're not trying to test your knowledge of the entire healthcare system here and how to deliver perfect care. The important point is that you're hearing the patient's issue and that you're trying to give them a strategy to show that you're going to be proactive. Okay, then down into clinical governance. Multidisciplinary team kind of hit on that already, and then clinical governance. Obviously, you don't have the ability yet to influence the wider picture of policies throughout the HSE or whatever country you're going to work in, but you should have a knowledge that, for example, if you audit what you do locally, that feeds into a bigger picture of providing information as to why things go wrong and when they do go wrong, and that can influence policy at a later stage. Yeah? Okay, so you need to have a bit of knowledge of this process and this policy to be able to score really well in this station. It only takes 2 or 3 minutes to read this, but if you haven't looked at this before you go into that station, you're probably not going to get very far. You know, it'll be really obvious, and I can anticipate that in this type of station, people will either be getting 0 or 100. You know, there'll be very little in between because those who have prepared it will do really well and those who haven't won't. Okay, so then, sorry, Catherine, if you move down, I think the infographic comes next. Yeah, so this is a nice one too. It's on Moodle, but obviously once you have it on if you download it on your phone and then you screenshot just the infographic, it's nice to have. So that when you're practicing this scenario with your friends, you know what the normal process should be. Because the actor might say to you, as I said, okay, well, you're only telling me about this now, and it actually happened 2 weeks ago, a month ago, etc. And you'll see that it says there that you have to inform the user within 24 to 48 hours of the incident if practical. And you see where it says inform service users, support persons of the adverse event. Let's say it is something just like they had bloods taken and they didn't need to have the bloods taken. Is that still an adverse event? Yeah, so something was done to them that shouldn't have been, right? So there probably is minimal risk of harm, but it's still a theoretical risk, so you're still meant to tell them. Do you understand what I'm saying? So we might give you a situation where what it sounds like was a near miss even. Do they need to be told about a near miss? So let's say they were prescribed Seroquel and they were meant to get Serenase, but no one actually ever gave them the Serenase. Or sorry, no one ever gave them the Seroquel. So the event didn't happen then, so then you don't have to tell them about it, right? But you still would have to go through your root cause analysis of why that happened. But if something actually was done that could potentially cause harm, even if it has not resulted in harm, obviously now, you should still tell them about it. Okay? One would be like someone is given a dose of an antibiotic and they seem fine afterwards, but they weren't ever meant to get that antibiotic. You would still have to tell them about that. Yeah, so it doesn't look like there's an obvious injury to them, but something happened that has a theoretical potential for harm. Right, yeah. So the question was, if they had bloods taken and there was no need for them to have them done, could you send the bloods to the lab still? So the point is that you should... What do you think in that situation, guys? Anyone got any answers for me? There's no yes or no answers on this. Yeah. So, I mean, what I would do in that situation is tell them that we've taken the bloods and ask them, do you want us to proceed with processing them? Because now you have taken them. But you also have to take into account the fact that every time you do one blood test, it takes up money, and therefore that's money that could have been spent on someone else who actually needed it. So unless there's a good reason for doing it, it probably wouldn't be the best thing to do. That's probably not the kind of scenario that we'd ask you to go into. You know, we'd probably just give you the information of what we want you to do in terms of disclosing the medical error, as opposed to trying to get consent for them then to process bloods and then making a decision around it. We wouldn't make it that complicated. Okay. Yeah. Everything that was said in the previous stuff is basically in that infographic. The only added thing is the thing about the 24 to 48 hours being the recommended cutoff, if practicable. And then we move down into the ASSIST model. So the ASSIST model is this model that's used for open disclosure, and there are 6 stages to it. So A, acknowledgement; S, sorry; S, story; I, inquiry; S, solution; and T, travel. And it gives you suggested phrases to use for each of those. Story and travel, I don't understand why they've used those particular terms for it. I'm sure if you go into the literature, you'll find out why. But let's break that down. So when you were doing this scenario in the OSCE, that's what we'll be looking for. Did you go through the process of the 6 steps? And this is all on Moodle, by the way. If you're looking for it, it's down in that very bottom folder. So acknowledgement, we're here to discuss this. I need to tell you about something that has happened, which shouldn't have happened. Unfortunately, an error has occurred, etc. Okay, so there's a variety of different ways of putting the information there. So acknowledging what has happened and that you understand that they might be angry or disappointed about it. Apparently, one of the things you're not meant to say is, I understand if someone is getting progressively more angry with you, because apparently it escalates the anger. No one's ever been angry with me ever, so I can't really speak from experience. No, I just passively aggressively text all my anger instead of confronting it. It's very healthy. I recommend it to everyone. But that's the only absolute no that I've been told. I don't know that there's any evidence for it. Just if any of you start Googling about how to do an open disclosure confrontation, you'll see it written, never say I understand to someone who's angry. But then I see in this one, like, they have written, I understand that you're angry, disappointed. So it's different protocols use different words. The sorry one is the one that's very important to get out. I'm sorry this has happened. I'm really sorry that X occurred, etc. I would never use the phrase I truly regret in real life, so I wouldn't in this situation too, because I think I'm going to sound really artificial if I do. Okay, so none of this language is stuff that you absolutely have to use. These are samples, and I think it's really important that you practice this station, or you are going to come across really artificial and robotic if you haven't. Then story. The important part around story is let them tell their story. So from their perspective, what about this is bothering them, or is there something that they want to say? Basically allowing the patient to have a voice. That's what I understand from their story. And then your story, is it okay for me to tell you where we're at with this in terms of what I think we should do next? Okay, that's kind of what they mean by that. Then if you get onto the inquiry part, trying to clarify, is there any further questions or worries that haven't come up yet? Do you have any questions? How do you feel about this now? Is there anything that isn't clear? Then solutions is, I think, what do you think should happen now is something that I would use in real life, but in a 5-minute OSCE station with a simulated patient is probably not going to be that useful. So I would probably err more towards, do you mind if I tell you what I think we should do? Because I think that that's more achievable you have a very short period of time. And then travel. I don't know why they call this travel, but for me it's like that whole idea of it is that it hasn't ended here, you're here, there might be further steps along the way that we need to talk about, like, you know, maybe you need to they might need to get further tests done in a few weeks' time because of whatever happened to them, like say the patient who gets contrast, they'll have to get their UNEs done several times afterwards to monitor that. Yeah, and GFR. You're probably going to have to inform their GP that this happened. You'll definitely have to inform their nephrologist that it happened. If it's something much bigger, they might have to come back in and make a statement to the risk management team and stuff. So there might be sort of follow-up things that need to be put into place. So I think that's what they mean by travel. If anyone else has more experience about this and wants to chip in, please let me know. What I can tell you, we don't need that part for now. I think that's all quite intuitive and you can read about that later. What I can tell you from the OSCE point of view is that what we will really be looking for is, the things that we will value the most is that you have the acknowledgement, the story, getting it from their point of view, the inquiry. And for a solution, as I said, you don't have to necessarily come up with a perfect solution, but you have to demonstrate that some effort is being made to try to find a solution as to why this has occurred and to prevent it happening in the future. If you talk to patient representative groups and the people who deal with medical error, what they will tell you is that 90% of cases will not be escalated or will be resolved initially if the patient gets three things. And that is acknowledgement, an apology, and what do you think the third one is? Some sort of explanation as to what happened so that it won't happen again. Patients really that part is really important to them, that this won't happen to them or to another patient in the future. Okay? And that makes sense, doesn't it? And we'd all want that as humans anyway. So, time-wise, where are we at? Quarter past. So, Catherine and I are just going to try and go through that for you within the context of the one where the patient has got the contrast when they shouldn't have, okay? But can you see that this could be applied to a variety of different circumstances, and so you should consider that, okay? Any joy getting it to change back to the screen?
So I hit stop content.
Guys, those of you at the back there, I know you're probably just Googling this because it's so fascinating, but on the off chance that you have a second, would you mind seeing if the remote control is in the back room, please? Any of you, I don't mind.
Yeah, I think it must be on the front. Unless it's like video, it's not video conference.
So, yeah, do you mind bringing that down? That's probably faster than me trying to tell you what to do. Does anyone have any questions before we get started? I know this is probably less exciting to you because most of you feel that by getting to final year in medicine, you have probably got decent communication skills already. But what I can say is that for anyone doing a, so we said this one. This doesn't seem to be doing anything. I don't know that that's working now. It is the right remote. Do you want to just call Ray and see? We may not be able to get it working, in which case we can go through it next week if you feel like you do need an enactment of it. But there's notes on that one already. So for comm skills already, I think things that we've done so far are we've done taking consent, and Catherine put up a link with a load of documents related to different procedures so that you could see the plain English description of each of those common procedures, plus the common risks and the serious risks for each of those. Did you find that link? Everyone know where it is on Moodle? Okay, so if you go into the announcements on the medicine page, there should be an announcement there from Catherine about 3 or 4 weeks ago. Did you upload it as well, the link? You put it on an announcement, but did you upload it into our folder? No. Okay. Yeah, but you can put it on a Word document or something. Yeah. So can you find it there? So it's in the announcements. Yeah. On the medicine page, not on the admin page, on the medicine page. Everyone able to find that now? Okay, so you should be able to find on that all the different procedures described in plain English and with common and serious side effects for each of them. I think there are hundreds of them there. Obviously, you are not expected to go through them all, but look at the common ones. So we said for cardiology, things like angio, echo, and pacemaker insertion and cardioablation, for example. They were the only 4 for that. Okay, he's on his way. Okay, so consent was one, and that was the resource to use with that. Is anyone not able to find that? So you go onto the medicine page, and then the announcements part in the medicine page, which is at the top of it. You found it now? Yeah. Okay. Then there's we've also done handover, and we used ISPAR for that, and there are 2 documents related to ISPAR in your resources there as well. Yeah. Everyone find that? And then we did explaining a medication, and what did we say the resource for that was? Anyone? So we said to use the PharmaQuest app. Okay, so if you go to the App Store, it'll come up. It either comes up as PharmaQuest or Medicines Information Cards. I can't remember which. And you can download it for free, and it gives you access to the top 20 drugs for free. But then, in order to get the top 100, which is what we recommend, it's $4.49. And I don't have $4.49 to give all of you. I wish I did, but I can barely afford. It's either under PharmaQuest or Medicines Information Cards. It comes up in PharmaQuest, and is that iOS or iOS? And Android, I'm not sure. It might be different. So you can download it for free, but then you only get access to 20. And then if you go for top 100, you have to pay. And the top 100 are what we're recommending you have for the OSCE. We get no kickbacks in this. We're not involved with this app at all. Someone in the UK made it, and 16 medical schools have adopted it there. So we thought it was the best one that we could find at the moment for the same purposes. And then you will see, for today then, we have put up documents about open disclosure. Okay? So every communication skills. And then we've also done some history-taking ones as well. So we did some history-taking ones in renal and in respiratory. Okay, so you should have ideas for all of the com skills ones that can be asked from this folder. Okay, and there's a few others we haven't done yet, like Breaking Bad News, for example. So we'll do them as we go along. Okay, doesn't look like we're going to get this done before time is up today. So I might just go through some of the questions I've got from different people about the OSCE, so that we can have clarity on that, and then we can go through this if you want in exam. So I got a good few questions about the long case, but I might leave that for the moment. For the prescribing tasks and the short cases, what should you expect? So for most of them, you should expect just that you have to prescribe a medication. Okay. Sometimes you'll be told what the medication is. For example, if it were a controlled drug, they might say you are to prescribe morphine sulfate for this patient. And then the main thing that we're testing you on is, do you know which prescription that controlled drug is given on, and do you know the legal requirements for writing a controlled drug prescription? Or it might be that we say to you, this patient has a community-acquired pneumonia, and please put them on an appropriate prescription for that, so therefore you actually have to pick the antibiotic to give them as well. Okay? All of the cases will be very similar to the half-day teaching that you get in your ECP OSCE. Any of you who are doing the PSA prescribing assessment will obviously find that helpful for it too. And the only drugs that we will test you on in the OSCE are those top 100. Okay, so we will only ask you to prescribe any of those. You will have a BNF with you in the OSCE as well. Please don't steal it, because you all know that causes loads of trouble for us. So any other questions about the prescribing part? Because we're not going to be doing that in these sessions. Okay. Medication review, if as in with the patient. Yeah. So we'll be going through that in this session in detail. Okay. Other questions I've got asked then. Sorry, who else? Bart, do you have a question? Oh, no. Yeah, the question was prescribing would only take a minute or two. You would be surprised how long it takes people to do a prescription. And I think that's fair enough. If you want to look up the page in the BNF and make sure that you get the right dose and stuff, and you have to actually physically write it out and make sure you've checked it all, I think 5 minutes is reasonable. It might actually only take you 20 seconds. It might take someone else 2 minutes, but we would prefer you to have excess time rather than too little time. Okay? So don't think that there's a hidden thing there that you're missing if you get it done faster. Okay. For stations that require us to give information, what's the best resource to provide? So it's the one that's in the announcements page. Catherine's also going to put it onto a Word document. It's just a link, and she'll put it into that folder there for you as well. Okay. What else? A lot of questions about the long case. Do you guarantee to get one medical patient and one surgical patient? No. Nor are you guaranteed you'll get one outpatient and one inpatient. So you could have two very similar surgical patients, but you'll have two different sets of examiners on 2 different days. 70% of the patients in the hospital are medical, and patients can cancel at the last minute as they are perfectly entitled to. So we just can't guarantee that. All right. But you will have 2 medical examiners and 2 surgical examiners. So, for example, if I'm on a case and it's about, someone having a hernia operation, I'm going to ask you absolutely nothing got to do with that, because I barely know myself. And I will ask you stuff about, oh, well, he also has COPD. Tell me about the medications he's on for that, or what would his pre-op assessment be. So even if a case looks like it's very surgical, the medical examiner will ask you medical things about it, and vice versa, okay? And next question, the 40 minutes in the long case, we'll be going into this in a lot more detail nearer to that exam, but 15 minutes for history where nobody disturbs you, you just talk to the patient, 5 minutes to present it and discuss your differential, or if they've told you in the first sentence, I have cystic fibrosis, you're not going to be discussing differential, right? You're going to be discussing their problem list. And then 10 minutes for examination and 10 minutes for questions. So 15, 5, 10, 10. And the questions can be about whatever the examiners think is pertinent to ask you about afterwards. So they might say, like, we have a patient who comes in and he has a very long vascular history as well as having a very complicated renal history. So sometimes we will focus on his vascular stuff, sometimes we'll focus on his renal stuff. Sometimes we'll ask a bit of both. Similarly with his examination, we might say, well, start doing a renal exam, and then 5 minutes into it, they might say, I'm going to stop you now, and can you palpate for a AAA? Okay, so you have to be... The best skill to practice for both your OSCE and your long case is to be moving between exams and different types of questions very frequently. If you practice for your long cases and your OSCEs by sitting in the library or at home with books, you probably won't do as well as you should, because you have to practice physically doing the examinations and talking to people and listening to you give answers out loudly. All right. Any other questions, guys? Sorry we're not able to change this back, but we can do it next week anyway, to make sure. Sorry, Gray, we got you to come over for me to say that there was no need to come over. Poor Ray, he's very long-suffering. He's had to put up with me for a long time now. Okay, anyone, any questions before we finish? You just want to go and have lunch? Yeah, okay. All right, thanks very much, and thanks to Sultan again.
Upload that consent thing on a Word document.
Thanks a million. It looks like loads and didn't know where it was.
I know, that's it. Yeah, you do try to take it over twice.
Okay, well that's good.
So maybe you could
Yeah, because I just feel like such a shitty. Like,
I know, same. I was like, who raised you? Like, okay, I was like, well, I'll take over. And he was, okay. And then he was like, okay, still not working.
there's no point in starting doing it now. I just,
Oops, wrong out.
yeah, it's not a big to do.
It will manually mark it.